Hi, I'm Brandon Twyford. I am Associate Editor at Massage and Bodywork magazine. I'm excited to introduce Ben Benjamin and his session at the ABMP Head and Neck Summit titled Deconstruct Headache Pain. Your client's headache. Is it a serious disease, a soft tissue injury, stress, or something else? In this hour, Ben will help us figure it out. Ben Benjamin, PhD, has been practicing massage since 1963 and founded the Muscular Therapy Institute in Cambridge, Massachusetts. With a passion for helping individuals cope with and overcome pain, Dr. Benjamin has been lecturing internationally for more than 35 years. He is the author of Listen to Your Pain, Are You Tense?, Exercise Without Injury, and the co-author of The Ethics of Touch. Ben was inducted into the Massage Therapy Hall of Fame in 2010. I recently had the opportunity to participate in a video shoot featuring Ben's work here at the ABMP office. Ben was amazing, so I know you'll get a lot from this session. Enjoy.
Thank you for coming to the ABMP Head and Neck Summit. So I'd like to start out by thinking about the goal. What are we doing here? So the goal is learn how to distinguish between the various causes of headaches and head pain. And they're kind of different. And we're going to be talking about that as we move along. I'd like to have you keep some things in mind. Do you think that, are stress-caused headaches the most common kind of head pain? How many headaches per year do you think are a normal thing to have? Do you know what else causes headache-type pain? And can you tell the difference between a muscle tension headache and a migraine headache? Just keep those in mind. Are they things that you know now? But hopefully you'll know them later. So first of all, let's start with what is a headache? Like, my head hurts. And it can be caused by lots and lots of things, actually several hundred things. But when a person's head hurts, for no matter what reason, they call it a headache, even if it really isn't a classic headache. And so you might think for yourself, how many headaches a year do you get? And we'll talk about that, what's kind of normal, a little later. So what can cause head pain? First, if you're thirsty and you haven't drunk anything, you're dehydrated, that is something that causes a headache. That's something that can stimulate a headache if you're on the spectrum to tend to get headaches. So always being hydrated is pretty important. And of course, everybody associates headaches with stress. If you're stressed out, you get a headache because it elevates the level of stress and tension in your body, and easily can cause different kinds of headaches. Allergies also can create headaches. You just get around some kind of perfume, or you get around, you eat a certain food, or you have a lot of pollen exposed to you, you might get a headache. All sorts of reasons. Just taking birth control pills, anything that sort of destroys or makes your hormones do something different. And that usually is in women, not so much in men. Although it can happen in men. And of course, if you get a concussion, whether you have a whiplash, or you bang into something, you fall down the stairs, or if you play football or some kind of contact sport and you get smacked in the head, your brain gets traumatized, and that can cause headaches that can go on for quite some time. And the kind of head pain that people don't usually understand or even think about is neck injuries causing head pain. And there are certain parts of your neck that will refer pain to your head, the front of your head, the back of your head, the sides of your head. So we're going to talk some about how pain can be referred to the head. People call it a headache, but it isn't really. It's really a referred pain to the head. And you can have combinations of these kinds of head pains as well, which we'll talk about a little bit later. Now, more than 200 diseases can cause a headache pain. If you have angina or certain heart conditions, you'll get a headache. If you have subarachnoid hemorrhage, that can cause a headache. If you have a cerebral aneurysm, that can cause a headache. A friend of mine just recently had a colleague who went to the emergency room, had a splitting headache, and he went over to the desk, oh, you only have a headache, sit down, wait. He waited 5 hours and then died, sitting right in the emergency room. So doctors make mistakes too, but we don't want to make that mistake. And that's one of the reasons we always refer people to a physician before we seriously treat them for headaches. Also, brain tumor. I had a student who was testing a student for neck problems, and when you turn the head, it's supposed to be very, very strong against resistance. And this person had a very weak head. Didn't really want to go to a doctor, but this therapist said, hey, you should really go to a doctor because I want to be safe treating you. And it turned out he had a brain tumor. And had he not gone to the doctor, he would have died. So very important. Meningitis also can cause head pain as well as different kinds of cancers. So there are several kinds of headaches that are classified, and we're going to work with a couple of them that hands-on work can deal with. But the one we think about most is probably migraine headaches and tension headaches, called muscle tension headaches usually. So there is also cluster headaches, which are kind of horrible, and people have those in a certain configuration, which we'll talk about later. And people can get true sinus headaches, and also sort of people think they have sinus headaches but don't. We'll talk about that. And then rebound headaches would have to do with medication. So you got the body-based headaches, which are things that our work can help. If you are treating somebody and they truly have a rebound headache, you're not going to help them. If they have an injury-based headache and you don't know how to work with the injury, not going to help them. But if they have migraine or tension headaches, the kind of work that I do, that I teach, can really help that person never have headaches again, or have them, minimally. So just reminded right now of a young woman. She was about 19 years old. Her parents brought her in to see me in my office. She'd had headaches since she was 13 and very slowly became antisocial, didn't want to go to school, didn't want to hang out with friends because her head hurt all the time. And I began to treat her, and she had a combination of two kinds of headaches: neck injuries that were referring pain to her head that stimulated the tension headache. And so we treated those for about a month, and she was blown away because her headaches were like, once a week, minimal, and she could do the exercises I gave her, they would go away. Then I went on vacation for 3 weeks, and her headaches came roaring back. So that was actually good because then we knew what I did something. So then I treated her consistently for a period of 2 or 3 months, headaches gone, and actually she ended up changing professional ideas, became a therapist, went to my school, and she now treats people for headaches. So, and that was like a number of years ago. So let's talk about muscle tension headaches and what you actually look for. So first you're looking for location. Now when somebody has a muscle tension headache, it's oftentimes on both sides of the head, and it changes. When you have a migraine headache, it's a little different than that, and we'll see that as we go along. So it could be like a spot, that you get when you get a muscle tension headache. It could hurt in the front, kind of in the sinus area, under here. It can hurt on your scalp. It can hurt around your head, like a band of tension around your head, like somebody is having a vice around your head. I remember once I had a headache. I got really upset. It felt like somebody was tightening like a metal band around my head. And then I really understood. I don't usually get headaches, but I understood and had more compassion for my clients that had headaches. Also, very common is to have an occipital headache, either on both sides, one side right in the back of the head. Also temporal headaches, one side, both sides, but usually switches if it's a muscle tension headache, and also around the eyes. With a migraine, it's going to be different. It's going to be behind the eyes. So now what kind of pain do people have? Well, they can have different kinds of pain. So it could be like an ache. It could be like a throbbing. If it's a pounding, it's going to be a lot more intense. Sharp, it's going to be very intense. A dull headache that happens over time, a little less intense. And a person could have intermittent, hurts for a while, then it kind of recedes into the background. They kind of forget about it, even though it's there in a little bit of a way, and they might be squinting. And so all of these are the types of questions that you ask a person. So duration and frequency. So how long or short means a lot in terms of how serious this condition is. So if somebody has a headache for an hour or so, not so serious. If it's a medium type of headache, it might be the entire day, whole day. They go to sleep, they wake up, they're better. But they can't really do anything about it, even with medication. And then people have very intense, long headaches, like for months. They just always have a low-grade headache. I had a client who somebody forced to come to see me who had actually 3 headaches at once, 3 kinds of headaches that alternated. He had a muscle tension headache. He was kind of in a malaise all the time. He had a migraine headache that would just put him out. Like he had to go to bed. He had to be in a dark room. Horrible. And he didn't believe that the work that I would do could help him. So he was totally negative. You know, they say the placebo effect. There was no placebo effect. He was an MIT professor, and his friend forced him to see me. So I did an evaluation, talked to him, and then we treated him, myself and my person who was working for it. And like in 2 months, his headaches were gone. He was like an advocate after that. His mind was blown that somebody could actually do that, which is exciting. My favorite thing actually to do is work on headaches, because when they're gone, the person's life is totally different, because your life is really diminished when you have headaches. You can't really do anything. It's kind of horrible. Okay. So let's talk about duration and frequency. You know, if it's longer, you know, it happens for a long time, it's going to be more serious. So if you have a little headache for an hour or two, not very serious. Easy to work with, get rid of. If it's kind of a medium type seriousness, the person's going to have it for most of the day. They might go to sleep, wake up, feel better. And then there are people who have very serious headaches that go on for, you know, days, weeks, months even. I remember I had a fellow who was forced to come to see me by a friend of his. He was an MIT professor, very skeptical, tried everything. And he had a combination of 2 types of headaches. He had a tension headache that was always with him, and then he would get a migraine several times a year that would put him in bed, and he just couldn't move. He put it in darkness, he had no sound, you know, it was crazy. And so he was not very interested in coming. He didn't think it would work, so there was 0 placebo effect. But myself and my assistant treated him for a couple of months. Headaches went away. He became our advocate. So you don't have to believe in it to have it work. And it was a great case, a fun case for me. So frequency. If you get headaches very frequently, of course, it's going to be more serious. So more severe. So people have severe, they have a headache every day. People are kind of moderate, they have a weekly headache, maybe 2 a week. If it's not so moderate, they might have a monthly headache, and that might be connected, for example, to a menstrual cycle. That sort of happens in that way. And then what's normal? Normal is 2, 3, maybe 4 headaches a year. And we all get over the top sometimes and we get a headache, but anything more than that is not normal. I remember I had a woman who worked in the office where I was working with an osteopath, and she came for a shoulder injury. And whenever I examine somebody, I say, do you have any other kinds of pains? Well, I get headaches once in a while. And she said, well, how often do you get headaches? And she said, well, yeah, just 2 or 3 times a week. And in my mind, I said, 2 or 3 times a week? Oh my God. I didn't say that. I was totally stoic. You know, I said, well, would you like us to work with that too? And she said, oh yeah, sure, whatever. She thought it was normal, because on the ads on TV, you know, it says, you know, take Bufferin, take aspirin, take Advil, take whatever. And so it was normal to have that many headaches. But it's not normal. So we treated her headaches and her shoulder injury, and you know, she was really happy. Okay, so not normal. So let's look now a little bit at the anatomy. These are the muscles of your head and face that can contract and give you a headache. And there are certain ones that are more likely. So if you have a muscle tension headache, the frontalis gives you a headache kind of in the front of your head, the orbicularis oculi around your eyes, the occipitalis, just above your occiput, can also be a contributor to headaches, and the suboccipitals, really underneath your skull in the back, can really give you nasty, nasty headaches. Could be on one side, could be on both sides, and these are the places that you look when you're looking for headache. And sometimes one of the things we do when we do what we call a tension test, which I'm going to be showing you a little bit later, is you're looking for the key starter of the headache, which I call the trigger. And it's usually in one of these places. And if you are treating somebody and you really get the trigger, you can really eliminate the headaches quicker, and you can give them ways to test their own neck so they know a headache is going to come and they know what to come see you more or to do a certain activity or exercise that I might give them. All right, so the pain mechanism for a tension headache is that, you know, there's a prolonged contraction of the muscles, and this leads to irritation of the pain nerve endings located within the muscles, and it hurts. The irritation may be mechanical, the muscles may constrict. It also might be chemical, metabolic waste products, which lowers the threshold, the pain threshold of the nerves. So, and there's also ongoing research. What really is a headache? And migraine research is ongoing, and we still don't know exactly what causes that. We have our theories, but the one nice thing is to be effective in treating it. So now let's talk about the stress point scale. when I explain to a client why they get a headache, they go, why am I getting these headaches? And so I explain, you should be at a level of 3 in terms of tension in your body. Your heart is beating, your lungs are working, your muscles are working, your eyes are blinking. You should have about a 3. So when I touch you in certain places, you should be relaxed, but you should have a certain level of tension. Now, life has a lot of stress in it, and that stress could be getting married. It's equally as stressful as getting divorced. Having a child is very stressful, and also it's very stressful to have a new job. Whatever it is, even if it's a great job, stress will be fired. So stress, when it increases, we need to have room to be stressed. So here we have on the chart, you can get to an 8 or 11 or 17, you're still fine. But if you live at a 17 or a 19 level, okay, 20 is when you're going to get a headache. So people who get headaches in a chronic way live at about an 18 or 19 level of tension. So it could be some fluorescent lights or a bad experience or something you want to say to somebody that you're not saying that pushes you over the limit. And so the idea of the treatment is to get them down as close to a 3 level of tension in the head and neck and maybe in their whole body, actually. So this is an easy way for the client to receive and understand that information. Does that sound right? Okay, great. So I think that a lot of headaches have to do with emotion and have to do with unexpressed or repressed emotions. Sometimes we know we're irritated at somebody and upset. And how many people actually speak it? I also teach communication skills, and lots of people hold on to stuff for years, sometimes for months, where they never get a chance to express themselves. Whether it's, and sometimes it's so repressed they don't even know. They may be angry, they may be sad, they may be afraid, they may be anxious. But if those emotions are kept inside, I think that's a large contributor to headaches. And you need to be able to speak your truth, or else something happens in your body that's not so great. And when we have the expression, this person has a pain in the neck, it's actually true that the interaction with them, not their fault, but the interaction with them is upsetting for you. If you have a boss that doesn't treat you very well, it's going to create certain tension, and that could give you headaches. So now let's talk about migraines, which are a different animal and a much more serious, much more debilitating kind of a pain. So yeah, let's go back to this anatomy drawing. And the places that you get a migraine are usually in the temporalis, here over at the temple, the masseter and pterygoid muscles. If you just put one of your fingers on your masseter right now, and you put your index finger on the temple, and then grip your teeth, and see what happens. They work together. The temporal mandibular joint means that those two muscles have you bite your teeth together. And when people are upset and angry or can't express themselves, in their sleep, they're grinding their teeth. And they wake up with a sore jaw, or maybe not, or maybe their teeth are just ground down. So this is the main place that you usually find. Also around the eyes you find it, also in migraines. Now it can happen anywhere, but there's a certain configuration. Location is the salient feature of migraine headaches. It's in a quarter of your head, okay? So that picture shows it, one eye, behind your eye, the back of that side of the head, the ear. So it's just like 1/4 of your head. And it's usually on the same side. Doesn't have to be. If it's on both sides, usually not a migraine. There are certain research happening now that says, well, maybe you can have it. But in most cases, it's in one quadrant of the head. And often the temporal is where it hurts and behind the eye. It's always on one side. And you have a host of other symptoms when that happens. So it can be moderate, just horrible but not so bad you can function, or it can be excruciating, where you cannot function at all. You have to go to a room, be by yourself, be quiet. You just can't do it. Or you got to take some medication. Sometimes it works, sometimes it doesn't. It could be a throbbing, a pounding. It could be very sharp. I had one person describe it to me like it was somebody stabbing a knife in her head and turning it. And it can occasionally, when they're not so bad, be a kind of dull, aching sensation. Now, they can usually last between 12 and 48 hours. That's their norm. They can be longer, but that's the norm. And when it's very, very severe, they happen in a daily way. They're not going to happen occasionally. They happen all the time. but mostly they happen once or twice a week when someone has a severe condition. And they usually last again. So if you have it twice a week and it lasts for 24 or 36 hours, you have one most of the time. Moderate, once or twice a month, and mild, 5 or 6 times a year. You can sort of live with it, take some medication. But medication is not the answer. Why are you getting that migraine? Can you do something that actually can get rid of it in a more permanent way? That's what I was always interested in. And getting a migraine and headache is never normal. It's not a normal thing to have. It's a very severe thing to happen to a person. So the pain mechanism, as I said earlier, is not really fully understood. There's also genetic factors. If your parents got migraines, it's likely that you'll have a tendency toward them, but it doesn't mean you'll get them. Just like any disease or anything, it doesn't mean you'll get it, but you have a tendency in that direction. And also you're in an environment where the family maybe doesn't express themselves. So that might be another kind of factor. Now, one of the previous theories, we're not sure it's correct, is there's a vasodilation, there's a constriction of the arteries, and then there's a vasodilation that presses on your meninges. That's one of the theories of why it has that. So also it can press, your trigeminal nerve can get activated. Again, we don't really know. We just know that people suffer a lot from it. So now there are certain other things that will trigger a migraine. Certain foods like aged cheese, salty foods, processed foods, skipping a meal, not eating, definitely can trigger an attack. And also food additives. There are so many food additives that a person can have an allergic reaction to. Aspartame is one, monosodium glutamate, MSG, found in many foods, can also trigger a migraine. Also, when people drink, I have many people, if they drink wine particularly, they're going to get a headache, so they've got to avoid wine unless they want the wine, and they're going to know they'll suffer a little bit later on. Also, caffeinated beverages will also give you a headache, like coffee or soda that has a lot of caffeine in it. And also certain medications like oral contraceptives that I mentioned before, and also vasodilators such as nitroglycerin can also activate it. Now, of course, we're going to have, I said stress, and stress also will cause and trigger a migraine, that's for sure. When we get upset and we go up above that level of 19 to 20, and your thing is migraines, not tension headaches, then you get a migraine. And if you sleep too much or too little, you also can get a migraine. I know people, if they sleep like 8 or 9 or 10 hours, they'll get a headache. If they don't sleep enough, they'll get a headache. So their whole metabolism kind of gets annoyed, so to speak. And then physical exertion. If you really have very physical activity, that you're rock climbing or you're running or a marathon, that can also stimulate a headache. Too much is moving in you, too much energy is moving in you, and even sexual activity can also stimulate a headache. And also sensory stimuli, which I've mentioned a little bit peripherally. If you're around lights, that makes the migraine worse. If there's loud sounds, it makes it worse. Even strong smells, paint thinner, paint, perfume, secondhand smoke, all these things can make migraine people go kind of nuts. Then there is the environment that you're in. When there are weather changes, where the barometric pressure changes. And then there's the family history, which I also mentioned. If you're in an environment of a family where things are not expressed, how many people here are in a family where people expressed and said what was on their mind? Or when they got mad, but not crazy yelling, screaming, but really told a person. When you're in an environment like that, then it can be perpetuated, not necessarily genetically, so to speak, but environmentally within your family, because we pick up those things when we're very young, and that can be a big factor. Also your age. Like little kids, you usually don't get migraines, but you can get it when you're an adolescent. They usually peak in the 30s, but again, you can have them at any time. Now let's talk about sex. More women than men get headaches of a migraine type, but more boys than girls get migraines. So somehow it switches over, and it may have to do with the hormonal changes when menstruation starts, but we don't really know. A lot of things, we don't know more than we do, is for sure. Okay, so then there are hormonal changes, And fluctuations in estrogen seem to trigger headaches in many, many women, and they're often controlled by some medication. And women with a history of headaches often report that immediately before or during or immediately after the start of their menstruation, they'll also get a headache. Now, there's also a drop in estrogen, which may account for that. And other people have a tendency to get headaches when they are pregnant or when they have menopause. I recently had a woman come to me, again, another person forced to come by her mother, who was helped by my work. And she came to me because she's had headaches since she was 7 years old, and she'd lived with it, but now she was pregnant. She was 30, and she couldn't take the medication, and she was having headaches like crazy. So finally she said, I'm going to bite the bullet, go see this guy. Again, didn't have a lot of faith, didn't have a lot of faith because she had tried a lot of things, and nothing biofeedback and medication, and it would only work to get rid of it at the moment, but it would always come back, and she would get many, many migraines. So we started to work, and what she had was a combination of neck injuries, which created pain in her head, which then stimulated the migraine to come on. And no one had ever looked at her neck. So we treated her neck, and we treated her migraines, and she had a fantastic pregnancy, hardly had any headaches, and she was a happy camper, especially because her mother paid for her treatments. But she is now pregnant again, actually, and was doing too much work and said, no, I've got to see you regularly, whatever, and just last week said, I was read the riot act by my gynecologist that I've got to see you twice a week during this because I get a tendency. Now, why does that happen? When you're pregnant, you get a lot of energy moving in your body. And we're going to talk about energy in a couple of minutes here. So that's that. Let's move on. So migraines are kind of more than just a pain in your head. There's an additional whole bunch of troubling symptoms that happen that I want to talk about with you. So first is called the aura. And if you've never had a migraine, you don't know what it is. So a migraine, you kind of get the signal. Your body tells you about 20 or 30 minutes before that you're going to get a migraine. And what it does is you get like spots in front of your eyes. Your vision might blur a little tiny bit. You might get tunnel vision where you only see this way, you have no peripheral vision. You might actually hallucinate. You just get different hallucinations, see visual kinds of things. You might be dizzy, which we call vertigo. Might get a general feeling of weakness, which in medicine we call paresis. And a part of your body, like your arm, might get numb. Some people have the same part of their body that gets numb. And also you might have some involuntary like twitches that happen in your body. So those are all symptoms of the aura before the headache even comes. And also a lot of other things happen. So as the migraine comes on, which I mentioned before, you get incredibly light sensitive. It makes the pain much worse. Sound, you cannot stand sound. But you also get nauseous, and frequently people will actually vomit when they're in this state. Sometimes people will get severe abdominal pain. In addition to the head pain, imagine you get a head pain and your stomach hurts like crazy. That's not so great. People have even heart palpitations because you're in imagine somebody driving a nail in your head. Like this is really intense, and it makes your whole nervous system go a little bit crazy. Also, you can get hot flashes, even when you're older, where your body starts breaking out into a spontaneous sweat. You got to change your clothes, but it could happen to men as well. You get this hot flash in your body. And also sometimes your eye drops. You lose control of your eyelid, causing eye drooping. And of course, you start seeing double sometimes. And sometimes you got to go to the bathroom like all the time. Frequent urination is another common symptom. So there are additional types of headaches, which I'm not going to talk about so much because the type of work we do, in my experience, can't really do much for them. Now, if that changes, I'll teach another class, but I don't think so. So there's cluster headaches, which are, if you think migraines are bad, clusters are really kind of horrible. So they're a very uncommon form of a headache, and they're characterized by excruciating unilateral pain, one side of the head, the whole head. Not a quadrant, but the whole head. Really unbelievable pain. People have talked about jumping out of windows when they get this kind of headache, committing suicide, because it is so intense. And they might happen in like clusters. You get them for like 2 weeks or a couple of months, and they stop. And they usually come for a particular person in a season. Like they might come in the fall, they might come in the spring, but could be any season, so it's not associated with pollen or anything like that. But they have a season for a particular person, which could change. Now, additionally, you get eye tearing and a stuffy or runny nose, and also eye drooping in this particular type. And there are then times of remission where a person doesn't get a headache for a long time, could years, and then it can come back. And I've tried, and I've had other people try, but I've never heard of anybody really getting rid of cluster headaches. A person has to live with it, and hopefully we will discover what's at the root of that and be able to do something with it at some point in time, but not now. Sinus headaches. Now, lots of people come in, they say, I have a sinus headache because it hurts on their forehead and it hurts underneath their eyes. Now, if they really had a sinus headache, I couldn't get rid of it. No way I could get rid of it if they really had a sinus headache, because a sinus headache is an infection that's in your sinuses, and you take medication and it goes away. But it's usually the location, and I call them sort of false sinus headaches. And again, you can treat those successfully, but they're usually tension headaches that happen to manifest themselves around the sinuses. And then medication. People can take all sorts of medication that can cause them to have a change in their threshold for pain. And then when they vary the medication or try to come off the medication, they have a really bruiser of a headache. And they have to come off it very, very slowly, usually under the guidance of a physician. When they mess around with it, that's when that happens. So those are ones we can't do much with. And they're a side effect, of course, of the drug. So now let's talk a bit about headaches that come from referred pain. Now, if you can see here, you see C1, C2, and C3. And that corresponds to the levels of the ligaments that are in your neck. So you have a set of ligaments that are called the supraspinous ligaments that are commingled with the nuchal ligament that go from your occipital protuberance, if you put your finger on the back of your head, on that little bump on the back of your head, and it goes down, like maybe a couple inches. And so that's your supraspinous ligaments, and they can refer pain to the head. Then you have, if you put your hands on the sides of your neck and you just feel underneath your mastoid processes behind your ears, the first 3 ligaments there can also refer pain to the head. They would refer pain to one side of the head, where the supraspinous might refer to the whole head. So if you have pain on one side of your head, it could be just coming from these ligaments. So these ligaments are really intensely injured in lots of people. And there are ways to test that, so you can say, oh, this is coming from your neck, not really a classical kind of headache. And as I described in some of the scenarios I spoke about, you could have one stimulate another. You could have a little neck injury because of pain, you don't feel so good. That adds the stress level, you're at a 19, you go up to a 20, you got a headache. So sometimes it's important to treat both. And what happens is you develop little injuries, little micro tears in the ligaments, and then they heal with scar tissue. Then when you turn your head, you look up, you look down, you cause pain in your head because you're tearing the scar tissue, and that will cause an ongoing pain for quite some time. So what are the initial steps? So first thing, the most important things, send every client with headaches to a doctor if they've never been to one before. And a lot of people have a fear of doctors. They don't go. And I told you that story about the guy who had a brain tumor. You have to make sure every client goes to see a physician before you start treating them seriously. So remember that more than 200 diseases, this is a side effect of headache. So here are a series. Now I teach a whole series of webinars. I have tapes. This is like a 20, 30, 40-hour course in how you work with the neck injuries. But here, just a very simply to look at, if somebody turns their head and gets a pain in their head or pain in their neck, if they tilt their head to the side and get a pain, if they look up at the ceiling, and if you can look at the woman looking at the ceiling, her head is flat to the ceiling. Can your head go flat to the ceiling without any pain? Or is it limited? That's an important test. And also, when you look down, your chin should pretty much touch your chest or almost touch your chest to have the right range of motion. And then we actually help the person. After we have them do that, we help them to move their neck a little bit further if there was no pain. If there's pain, you don't do anything because you don't want to just hurt the person. You're trying to get information, so we do a little assist in each of these particular tests. And of course, the person might have a disc issue, which involves doing 40 tests on the neck, which we're not going to do today, but that's another ball of wax. And you could have a disc problem that would be referring pain to your head as well. Okay, so that covers that neck thing. And here is in your handout that you can print out, this is kind of a summary of the things that I said. I'm not going to say them over again, of differentiating between the characteristics of muscle tension headache, migraine headache, and cluster headaches. So now let's move on to the energy factor, which I actually think is the most important, because I think most headaches that I've been talking about, what we call tension and migraines, are really an energy phenomenon. And when I work with people, that's what I'm actually thinking about. That's really what I'm addressing. So I'm just going to talk to you a little bit about the energy perspective. And you see that little guy down there is the armor. And that has to do with a doctor named Wilhelm Reich, who was a brilliant genius that most people didn't really understand, whose work has been proven to be true in lots of areas that he predicted like 50 years before medicine discovered them. And he postulated something called armoring, where we put on a kind of muscle tension in our bodies that holds our emotions. And we start doing that when we're babies and we're children. And so I'm going to just read to you, and it's set up there, how he defined it. The chronic muscular tension which an individual develops as a defense against the breakthrough of emotions and sensations, in particular anxiety, rage, and sexual excitation. And so basically, if you armor yourself, let's say you're sad and you're a kid, you're crying, how many people say, that's good, get it out? They say, shh, it's all right, or shut up, it's all right, don't cry. Or let's say a kid gets angry. Is a kid allowed to be angry? No, not really. Smacked if they get angry. So the kid develops an armoring to protect themselves from their environment, usually the family environment, that doesn't really permit the expression of children. If children get angry, they should be told to use their words, not to hit people, bite people. Use your words. And you train your child to express their anger at you, at whoever, at each other, without violence. And when you're sad, you cry. And that's fine. And knowing that that's an acceptable emotion. And for women, it's more acceptable, but for men, it isn't, and men get much harder in a certain way. But that's a natural expression. So we develop this armor, which is very useful when you're small, because it helps you survive. But when you're an adult, it's not that useful anymore. And so you've got this protective shield that you feel vulnerable, and you want to protect yourself. And so what it does is it stops the energy from moving in your body, which moves up and down and around your body. Your energy moves throughout your body, and that's a whole other thing to talk about for a couple of hours, but not today. Just want to give you a hit of it, so to speak. And what Reich did is he postulated that there were 7 different armored rings around the body, that ring was tightening your being and not permitting the energy to flow. And the therapy was loosening up that armor in a particular way that didn't unleash too much energy, but unleash just a little bit at a time. So you actually start at the top of the person's head, unleash a little energy, and then you move down, down, down. And for purposes of working with headaches, you just work with 3 segments. So I'm going to tell you what those 3 segments are. So first there's the ocular segment, which of course includes the eyes, and it includes the muscles around the eyes, the orbicularis oculi, the frontalis muscle, the temporal muscles, and the fronto-occipital that goes to the back of your head, just above your occiput. So that's one band around your head that, again, if you imagine yourself trying to cry and you wanted to stop crying, you would tighten those things up. So then we go to the oral segment, and the oral segment includes your jaw, which is your masseter and pterygoid muscles, your orbicularis oris around your mouth, the muscles around your mouth, and there are many others that could be involved, the mentalis and others. And then, of course, your suboccipital muscles over here. So if you would just take a moment and grip your teeth, maybe even close your eyes, and notice what happens in your suboccipit right under your skull in the back. See if you can feel the tightening in your occiput when you bite your teeth together. You feel that? So that holding back. So again, if I wanted to get mad, what do kids do when they get mad? They bite, they scream, they spit. They want to express in that part of their body. So Reich said, well, people hold back in that part of the body. by clamping and clenching their emotions and holding them back. And then we go on to the cervical segment, which is your neck. And the neck has two parts. It has an outer ring and an inner ring. So if you're going to hold back, if you imagine that you were going to cry, be sad, and you had to tighten that back, where would you tighten? You'd tighten your neck. And even more, you'd tighten inside. So we talk the other part is the throat, internally, muscles that are way, way inside. And there are ways that we work on those muscles as well, having corks in people's mouths and working with gloves inside the mouth and things like that to open that whole, and exercises you give clients to open their whole throat, which are very, very powerful and effective. So he postulated these parts of the body constricted and limited the energy moving through your body. And so I'd say that's always a factor, and you want to just keep that in the back of your mind as you're moving through. So let's do a little bit of a headache history. And in the headache history, you might ask some more questions that might come out of these questions, but let's go with what we've got here. So imagine also that you're going to be working with somebody for probably a couple of months at least with a thing that's so upsetting to this person, so painful. So you've got to develop a relationship, some kind of trust between you. So I consider the history taking sort of relationship building. They're getting to know who you are. Do you actually listen to them? Or do you interrupt them? Are you taking notes? Are you really writing down and seriously thinking about what they're telling you? They know what's happening. They don't know that they know necessarily. Sometimes they do, but the information they give you gives a lot of information. For example, just one illustration, if you ask the person, do you get headaches? When do you get headaches? Well, they'll say, well, I go on vacation. That tells you a lot of information, because when the energy starts to move, and they're more relaxed, they'll get a headache. So that's different than a person who goes to work and at 2 o'clock in the afternoon they get a headache because they don't really like their job. Again, their energy stops. So that's how you put all this information together. So you're gathering information, the type, the severity, all that. You're trying to differentiate, is this a neck injury that's referring pain to the head? Is it a combination of different kinds of headaches together? And this will help you determine what kind of treatment that you're going to give. Are you going to accent working with the migraine? Are you going to work with the neck? Are you going to work with the tension? Also, the various exercises that you might give them address all these different things. When we work with migraines, we work with a special light that a psychiatrist I know developed, where you're stimulating and actually working on the brain with a small little flashlight. And they're often very sensitive, so you have to put a black tape around it. So there's the pinhole of light for them to start. And then over time, they lose their sensitivity to light. And also, you might find out that it's not in your, bailiwick. You might find out that, they're getting weird, stuff that you don't understand, like the guy I talked about who had a weak head when he was doing resisted motions of the neck. So you might want to make a referral, or you might want to send them to a doctor before you'll seriously treat them. I mean, I don't throw them out the door if they've not seen a doctor. I say, let's do a history, let's talk to you, and then if you really need to see a physician, you do. And most people have seen, many physicians. So, question 1, after if they've gone to see a doctor or not. Have you seen a doctor about your headaches, and what did he say? You've asked them, what did they say? What's the information they have? And that information might be, they spent 5 minutes with them, they gave them medication, it may be they did an extensive series of tests. You don't know what they did. You just want to find out what they've done, and if they've not gone to a doctor, you might ask them, why? Because now, you're not telling them to go to a doctor maybe necessarily yet, but they may have had a really bad experience. And I always say to therapists, have a great doctor person that you know, who spends a lot of time with a person, who's a decent, caring kind of person. And there are a lot of them out there. You just have to find them. I usually refer all of those people to one doctor who will spend 45 minutes with them, talk with them. He's great. And they usually switch doctors once they meet this doctor. Okay. Second question, describe your headaches, and they're going to hopefully tell you where they are, their location, the type. You're going to get all this information we talked about before. Are they sensitive to light? Do they get dizzy? Just let them talk, and you're going to note down, do they fall in the migraine category? Location, quadrant. Do they fall in the tension category? Do they come up when they wake up in the morning because they might have slept funny with their neck, maybe the neck? And how long does it take? How many days it lasts? So I'm not going to go over this again, but these are the things you're looking for. How frequently do they happen? Ask all those kinds of questions. So is there anything that makes your headache better? Not working. Okay? So my main task with that person, and I've had quite a few, is to get them to look at, well, you're spending 8, 9 hours a day at work, and you hate it, right? So how about a new job? So that's I'm counseling the person. I also do professional coaching, and sometimes I mix them together. And the treatment was getting a new job, for a particular person, plus, of course, working on their head because their level was up at 17 or 18. So is there anything that makes it better? And you want to know about that. Now, is there anything that makes your headaches worse? For example, if they said, when I read, can you show me how you read? And they go like this. If their head is down, they're putting stress on their supraspinous ligaments. So then, head down, maybe ligament problem. Okay? So all these little questions give you, when they go on, sleep in a hotel, sleeping on a funny pillow. Or I always take my pillow with me because they know it's going to be bad for them if they sleep on something that's the wrong height for them. When I visit my mother, I get a headache. That happens, because you revert to all the patterns, that you had. I even had a person that if they got a call from their mother, they would get a headache within like 5 minutes. So because a lot of things are not expressed, they're not talked about. Okay. So what was happening in your life at the time when the headaches began? So something happened? It could be, I had one man who, there was a death in his family, and he never really expressed and dealt with it. So I suggested he get some counseling. I got a new job, or whatever it is, whatever happened, did something happen, or I had an accident. Oh, I had a mild, pain for a couple of days, went away, but now they have a neck injury, or they have a concussion, and that kind of thing. So did the headaches come on suddenly or slowly? And if they came on suddenly, what was the incident that happened? Or maybe there was no incident. Maybe it was just the last straw, or their life got too much for them, or their kids, started fighting. They were not an infant anymore. I've got a friend who's got twins, and the kids are like, from 6 in the morning until 10 at night, no nap. She can get a headache, because it's no rest for her. So that's when it happened. Or if it just happens slowly, you just want to know those things because they sometimes can tell you information. Do you experience any pain in your neck when you turn your head? When you do anything with your head? And did you ever have a neck injury? Again, another question around the same thing. The headaches recur in relation to your menstrual cycle. Of course, you only ask this to women. And do you take any prescription or non-prescription, drugs for your headache? Because let's say a person says, oh yes, and they are on Celebrex right now. Well, your testing, which I'm going to show you a little bit later, is going to be, it's going to be 5 times worse if they didn't have the medication. So what I do is I say, can you come in the next time, and let's have you come in the morning before you take your medication, so I can get a reading on what's actually happening, the level of what's happening. So that's that part. Now, I developed an assessment test that I mentioned earlier that we're going to work with. And first I'm going to show them to you on some slides. And then I'm going to show you a video that I prepared that is going to take you through in movement. And then we're going to have you try it, and we're going to see how it goes. And I'll be here to correct you and help you get it right. And again, you're looking for the most tense place. And how you do that, I've developed a little system of a pain scale. So if it's a 5, that means I'm applying very little pressure. So I'm just barely touching them. I'm pressing just with like a pound of pressure. And they have pain. That means it's a 5. If I press a little bit, moderately, and they have pain, that's a 4. And if I have to press with some good pressure, it's a 3. If I'm doing a lot of force, but not all of my force, it's a 2. And if I press all the way and have no discomfort, that's a 1. People should be at a 1, period, or a 2, but 3, 4, 5, you're discovering the level of tension at the particular part of their head and face that this headache is about. Okay? So, and you do this retesting frequently because you want to know, first you're going to break up the tension in the forehead, then you're going to break up the tension under the eyes, then you're going to break up the tension in the jaw, and you're going to move down. And if they have a neck injury, you're going to work with a neck injury simultaneously because unless you get rid of both, not going to work. Okay? So And here I'll just give you a sheet that you'll have in your handout that you can just mark the level number. Now I've done this in a whole class and had the same person be tested by 4 or 5 people to get their levels right. But you'll get the idea. And it's only levels for yourself. You know, when you're treating the person, if you can put all your weight pressure, they're good. If you're barely touching them, not so good. All right, so first one is you are standing at the head of the table, person's lying supine, and you're putting either the tips of your thumbs or the first joint of your thumbs, which I call the thumb point, right in the center of their frontalis muscle. And you lean down, and you lean. And as you're leaning, you don't count out loud because you don't want your client to think you're weird. So you're going to be counting 5, 4, 3, 2, 1. And you tell them, hey, I don't want to hurt you here. I want you to just tell me if you have a pain, you know, at any time. And tell me right away, because I'm just trying to test the level of tension in different parts of your head. So that's the forehead test. Then we're going to do the eye orbits. And you always want to have all of your fingers on the person's head so that they're not floating around. The person feels a sense of danger that you could slip and poke them in the eye. So your fingers, your thumbs are standing on the forehead, your fingers are on the side, and your index fingers are parallel and right in the corner of the eye, pushing straight up. And you might want to just put your fingers in the corner of your own eyes and just kind of press up a little bit. You're pressing straight up toward the top of your head. So that's the second test. And you might do them together, or you might do them separately, because one might be worse than the other, particularly if they told you they have headaches on one side. Then we do the nose, which is the nasalis muscle, and you're going to be pressing with your straight fingers. Sometimes easier to stand up to do this. And you'll be pressing as if you were doing crisscross with your fingers through the nose, kind of into it. You're not, of course, going to go through the nose, but you're going to be pressing, see if that is kind of tight. That's a place that gets it. Then you're going to be doing the under eye, where you're going to use the pads of your thumb very gently. The first time is gentle, 5, and then 4, and then 3. So you do it a bunch of times until they say, that hurts, or that feels good. Feels good? Nothing to do with that in the treatment. Feels like painful? You know, you got work to do. Then we're going to work on the jaw. Take the tip of your thumb, and you just press so you might just try it. Just press. If you want to find it, just grip your teeth, and then you find the center of it, and just press. And you should be able to press pretty hard without any problem whatsoever. But lots of people, having headaches or not, have a lot of tension in the jaw. Then we do the underjaw, the hyoid muscles, and so you put your thumb goes onto the base of the jaw here, underneath your lips, and your index finger goes underneath, and then you're going to press straight up underneath and kind of flip over the muscle under there. And then we're going to test the sternocleidomastoid muscles, and you just squeeze each one very gently, and then again a little more deeply, and then again a little more deeply. So you find out if that's a contributing factor that attaches up with the mastoid process, and so that may be an issue. Then you want to get the occiput, so you're going to now put your finger actually underneath the occiput and press up right between the spine and the mastoid process, sort of in the middle, just pressing up again very lightly, 5, 4, 3, 2, 1. This is a very common place that's really tight. And then you're just going to see, are they hunching their shoulders, and is that a general condition too? So you just kind of squeeze one shoulder at a time, 5, 4, 3, 2, 1. And then you want to see how they breathe. So you put your finger on their very upper chest, right where the manubrium is, and you're going to try to see how they're breathing. So when a person is breathing normally, their chest moves and their abdomen moves, because the lungs are where your chest is, and your abdomen moves only because your diaphragm goes down and pushes out your abdominal contents. So you want to see if they're breathing in both, and how much of an excursion. Most people don't use most of their ability to breathe. They use only maybe a sixth or so of their breathing capacity. So you ask them to breathe, and you watch and see if your finger goes up and if their chest moves. And you take a look at their abdomen and see if that's moving. They should be moving actually together, and the chest should move. And if you see that they're not breathing in the chest, ask them to move their chest a little bit and see if they can do it. Some people can't even do it. They're so contracted in their whole being, in their whole thorax, that they can only breathe a very short amount. And part of the treatment is the energy pump of the body is the breath, which lots of people in different disciplines in yoga and all kinds of people know. And if you increase the breath too suddenly, person will get dizzy, they might get, emotions might come out. So good to have a psychotherapy along with the treatment, particularly if it's not just a ligament injury, it's an emotion-based thing. So a person has a place to take what happens to them. Okay, so Now we're going to do the video demonstration so you can see what these techniques are like. You can see what the techniques are like, and we can then try them out. Okay? So the first is the frontalis muscle, and this is the forehead. So you go about an inch above the eyebrows, right about here on either side, in the central part of the frontalis. You use your thumb points, which are this distal knuckle of the thumb, or you could use the tips of your thumbs. I'm going to use the thumb point, as I call it. And so I'm going to press very gently. That's a 5, 4, 3, 2, 1. With a lot of pressure, that means nothing's really happening there, pretty relaxed. And I'm in a standing position so that I don't have to use much weight. Then I'm going to go on the very edge of the eye socket on the orbicularis oculi muscle. And I could sit or I could stand, doesn't matter. And I'm going to have my fingers kind of parallel, and I'm going to pull. And I'm also going to put my fingers on her cheeks so that I'm not wobbly. So here I have a good perch on her face. And I'm going to pull up. 5, 4, 3, 2, 1. And I'm pulling up very hard in the end. So that's the eye orbits test. Then we use the nose. We go to the nose. And we're going to go at the very top of the bridge of the nose for the nasalis muscle here. You might want to stand up. That might be a little easier. And you keep your index fingers straight, and you're pressing in the crease between the side of the nose here and as it meets the face. And you're right on the muscle, so the edge of your finger is on the sort of the cheek, and the other part is on the nose, and you're just pressing straight through, kind of like that. And you just go very little pressure, a little more, that's a 3, a 2, a 1. And again, your fingers are on the face so that you don't slip. You're just very solid there. Then we're going to do the under eye, and we're doing the levator labii superioris and the zygomatic, etc., major and minor muscles. And you're going to use the pads of your thumb, not the tips, pads, and you're going to go from the nose out, just at where the nose meets the face, going out like that. And you do 1 at very light, and you do 1, 2, a little deeper, and then to 3, a little deeper, a little 4, etc. And this can be very sensitive, so go very, very gently. As we call that the under eye. Now we're going to do the jaw, and we want to find out where those muscles are. So you ask the person to grip their teeth together for a moment, and you feel the masseter and pterygoid muscles, then they relax. You can use your thumb points, those joints again, or you can use the tips of your thumb, and you just press straight in. And again, very gently at first, a little more, a little more, a little more, a little more, and you should be able to go fairly deeply into that muscle. But that muscle is very tight on lots of people, so go gently and carefully. Then we're going to do the underjaw, where that's the digastric muscle. So you put your finger in the center, about a ½ inch back from the jaw line. Put your thumb on the lower jaw, and so that you have a good balance and something to push against. So you're in the center. You take the skin away, meaning in this case I'm using my right hand, so I'm going to go to the left. Then I press up, straight up toward the head, the top of the head, and I go across. And you're going to jump over something. So you're going to go all the way over to the side, press up, and you're going to bounce across a muscle there. Right? The digastric muscle here. And the tongue muscles, etc., the platysma, etc. Then we're going to go to the sternocleidomastoid muscles, the sterno test, and you're just going to grasp the central part. Over here at the top, it's very thin, and down at the bottom, it's thicker, but right in the middle, if you get it, and just squeeze it very gently on one side, 5, 4, 3, 2, 1, and then you do the other side, 5, 4, 3, 2, 1. Don't do both at once, just do one at a time, or you could do 5, 4, 3, 2, etc. Okay? You should be able to squeeze those pretty firmly without any discomfort whatsoever. Then we're going to go to the occiput, so you're going to turn the person's head a little bit. And you're going to use the tip of your finger. You're going to hold your hand like this to give some stability to your index finger. And you're going to just press straight up into the skull. Underneath the occiput, just straight up. It's where all the erector muscles, all the muscles that go into the suboccipital region, trapezius, etc., as they attach. So you go right in the center. You're going to feel the spine and feel the outer edge of the erectors. You go right in the middle. And then you're going to just press up straight toward the forehead, and with a 5, 4, 3, 2, 1 to see if that's painful. And then, of course, you do the other side. Do them one at a time. Then we're going to go down to the shoulders and the traps, and you're going to just squeeze the shoulder, one shoulder, then squeeze the other shoulder. And again, do it gently, and then as you do it, you go more deeply. 4, 3, 2, 1 is a lot of pressure. Should feel nothing but good. And now we're going to move down to the breathing. So now we're going to observe the chest, and it's easier to observe. You put 1 or 2 fingers on the sternum very high up here, and you see how much movement there is in the chest and also in the abdomen. Both should be moving. But if the chest doesn't move at all, it gives you a lot of information. So you ask the person just to breathe normally, and you just watch. You see if the chest is moving up and out. You notice if the lower or upper abdomen is moving as well. Both should be moving together, and sometimes they don't. Sometimes the chest is frozen, sometimes it's only in the belly, and sometimes it's erratic, going back and forth, and sometimes they work nicely together. And most people don't breathe fully, and you see how far the chest goes down, how far it comes up, and you just do that for a moment. And then you tell the person just to relax. And now so let's start with the forehead. You're going to be placing your thumb tips or your thumb points, those first joints, and just press straight down. Yeah, so you want to use more of this joint here. That's more of that joint. Or if that's not comfortable for you, use the tip of your finger.
What's that?
That's good. You want to have your thumbs facing each other? That way. There you go. And be sure you're bracing on the head. That's perfect. That's good. Great. And you just lean in and count to yourself 5, 4, 3, 2, 1. And if, hey, clients, if it hurts you, you just say, hey, stop. All right? Okay, so let's try the next one. For this one, you're going to sit, and we're going to have you do the eye orbit. So you're going to press with your index fingers. Okay, so you want to make sure your fingers are parallel, up like that, and you're standing on your thumbs like that. Yeah, make sure your thumbs are standing on the forehead so the person feels safe. Make your fingers parallel. Yeah, let me show you here. Mm-hmm. Let me show you. Yeah. So they're like that. Oh, okay? Mm-hmm. That's it. And then pull straight up toward the person's top of their head. Great, and a little more, and a little more, and a little more, and then stop. We don't want to kill the person there. Just learning it. Okay, great. So let's move on now. And let's try the nose. So easy to do the nose standing up. You're working on the nasalis muscle. And you adjust at the bridge of the nose, a little bit lower there. That's it. Make sure your fingers all, that's it, there you go. And you're pressing right in this corner here, right in the corner right there, where the cheek meets the nose. Go a little bit lower. That's it, great. Good, good. And then lean your weight of your body. You're not using your fingers particularly, just leaning your body. And more and more and more, and that's it. And you come out. Great. So now let's do the under eye. And for the under eye, using the pads of your thumbs, one after the other. And that's it. Brace your fingers on the body. That's it. That's it. And use the pad of your thumb, not the tip of your thumb. Tip of your thumb is too intense. So then one goes out to the side, the other goes out to the side. That's it. Just very gently. And then get a little deeper the next time. And a little deeper. Just go out about an inch. That's it. Take a little deeper. That's it. Good. You got the hang of it? Great. All right, so now let's go on now to the jaw. So I'm going to sit down again for this so you can be in a good position. And you can use the thumb tips or the thumb points. And now ask the person to bite down for a moment. Ask the person to bite. And then you can feel where the masseters are, and then have them relax. And now just press in on both sides together, very gently, a little more. Now be sure to tell them when to stop, because this is not going to be comfortable necessarily. There you go. That's good. All right, good. Great. All right, so now let's move on, and let's try the underjaw. So for the underjaw, you're going to put your thumb just above the base of the jaw, and that's it. And this finger kind of like this. There you go. And now you're going to take the skin, and you're going to move it over. And then you're going to press up toward the skull, top of the head, and then go across. And you'll flip over the muscle. You take your finger way over there, up, and pull across. That's it. And then do it a little gently, and then a little harder each time. That's it. And when people have headaches, this is often very tight. And you just do one, and that's it. And you can do the other side, too. You can do the other hand. But when you're testing, for testing purposes, usually just do one side. Okay. When you treat, actually, this is a one of the movements you do when you treat, and then you do from both sides. Okay, well let's go on to the sternocleidomastoid muscles, and just hold them in the center, and just squeeze one, and then squeeze the other very gently. That's it. You got it. Very good. That's good. That's it. And that one's pretty simple. And now let's have you do the occiput. So turn the head to the side this way, and then having this hand just support the head at the forehead. That's it, just like that, so the head doesn't move. That's it. And then you're going to take your index finger, put your thumb in the middle of your first joint so that it's supported like that. And then you're just going to stick it right in the middle of, let me show you over here, between the spine and the mastoid, right in the middle there, right under the occiput. Right in the middle of that, a little more over. There you go, right there. And just press up toward the person's forehead, sort of diagonally through their head, and count 5, 4, 3, and tell them if it's too much. You should be able to use a lot of force, like 30, 40 pounds of pressure. That's it, good. Now try the other side. And turn the other way. And switch hands. And just press right up in there. That's it, right up under the skull. Just one finger, hold your finger like that, that's it. So you're supporting your finger, you don't hurt yourself. We don't want to have to treat your finger. Okay, good, that's good. All right, so that's the suboccipitals. And now just the shoulders, just squeeze the shoulders one after the other. It's pretty easy. And just see if they're reactive at any time. You go 5, 5, 4, 4, 3, 3, etc. Should be able to squeeze pretty hard, should have nothing much. Okay, so now take your fingers, 2 fingers, and put them right on the top of the sternum. No, just 2 fingers there. That's it, and up like this. Just very gently, right there. And just watch the person breathe. Ask the person to breathe, and just watch how they breathe. And see, is the chest moving at all? Sometimes 0. Sometimes it moves and the abdomen doesn't, or sometimes only the abdomen moves and the chest doesn't. And ask them to breathe a little deeper now and see what happens.
You can start breathing a little deeper.
And you can see if they're coordinated. They should be moving kind of together, because as the air moves into the lungs, the diaphragm pushes down and the abdomen goes out. Okay, great. So now we're going to switch, and the other person's going to do it to you and get even. All right. So you've learned how to distinguish the various causes of headaches and head pain, and they are different as you've seen. And you can use this webinar as a guide to apply the techniques that you know already to treat your clients. We have 2 options for you to learn more about the topics that we discussed. You can learn my approach to treating headaches and neck pain through these 2 online courses that cover everything from assessment to treatment. There's a 7-part one on headaches, which goes in great detail. And then there's the one on unraveling the mystery of cervical pain, which is a 6-part webinar series. Now, do you have any questions that you would like to ask?
How do you treat migraine and muscle tension headaches differently?
Well, first you have to know where the triggers are for the different types of headache. So when it's a migraine headache, it's going to be in a quadrant, so you're going to be spending a lot of time working on that quadrant. You're not going to be working equally everywhere. When you have a tension headache, it's usually bilateral, it's on both sides, so you're going to be working in a different way. Remember, the migraine is a sort of a deeper, longer lasting headache. It's usually been around for many, many years and has often a lot of energy and emotion behind it. So it's going to take a much longer period of time, and you tell the client it's going to take longer. You know, it's going to take many months, probably 3 or 4 or 5 months to get it really gone. With a tension headache, it usually takes just a couple of months for them to see real fantastic progress. Another piece is that when you're working with migraines, a lot has to do with the eyes, because you know they're very light sensitive, sound sensitive, whatever. So this segment up here, the eye segment, is where you're going to be focusing a lot of attention first. And we actually have a special exercise that we do with this flashlight that I mentioned, where they follow a light and move their eyes, because sometimes when they move their eyes, they look up, they have pain. So you're trying to actually work the muscles of the eyes. And in exercises in the session itself, you have these very special exercises that they do that work with the migraine. So longer time, different places in the head that you work. Migraines, for example, you're going to work a lot also on the temporalis muscle, because that's often where it's centered, and maybe on the suboccipital. These have overlaps. And sometimes when you're treating the migraine, and then they start getting tension headaches, that's progress. Because it's a much more superficial, less intense headache. But sometimes you go through those progressions, and then you treat it as if it were a tension headache. Does that answer your question?
Yes.
Great. Next question.
How can you be sure if someone has a headache based on built-up tension and not neck injuries?
So remember, we just did this tension test, and if you have a person who just has a neck injury and not one based on tension, when you do the tension testing procedures, you're not going to find a lot. You're not going to find a lot of, tightness. You might find a little bit, but not to the level. And once you work on a bunch of people who have headaches, it's really intense. You just touch their occiput, you touch their jaw, they jump off the table. You're using very little pressure. They don't jump off the table. You're using little pressure, and you get a huge response. Now, if they've got a neck injury, then you're going to do these various movements of the head, and when they move their head, it's going to hurt. And they often say they wake up with a headache. So, and also, when you really learn the neck, you also palpate all the neck ligaments. You palpate all the neck ligaments on the side of the head, on the side of the neck, and in the back. And when you touch those ligaments, it's very, very painful. And sometimes it shoots a pain right to the place that they have a headache. And that's very impressive to them, because they never thought their headache's coming from their neck. So you just touch it, and they may have the pain. But if it's just tender at all, you should be able to use a huge amount of pressure on ligaments with no pain whatsoever. Does that answer your question?
Yes. Thank you.
Great.
Ben, is it preferable to work on the client when they are actually experiencing the headache, or should they not have the headache while we're working on them?
It's a great question. I often tell people to come in when they have a headache, if they possibly can, because that's the best time to figure out where the trigger is, because it's raging tight. It's very, very tight. You can barely touch it. So if you're confident in your work, then you could treat them with a headache. If you're just starting out, maybe not a good idea. But I love to treat people when they have a headache. I mean, I treated one woman who had a migraine headache that no one had ever touched during a 36-hour period. And so she came, and I worked on her. She was about at a 15-hour point. I worked on her. Headache was gone, and it blew her mind, because she realized that I could actually do something for her. And she started crying, because it was like amazing to her. So great to work on people when they have a headache. And also, your question leads to another answer, is that sometimes you have to tell the client the first time they come that they might get a headache as a result, and to tell you, because that means maybe you work a little too hard. And you want to work very gently as you begin. I know we didn't do the techniques for treatment, but just that information, when you work on them, you have to just push them a little bit. Push them a little bit so that they get a little looser, get more energy, but not too much.
That's very helpful.
Great.
So how much of an effect does nutrition have on headaches?
Well, diet and nutrition have a profound effect on headaches. I've had people, if I just had them cut out sugar, for instance, no more headache. Some people who drink coffee and it gets rid of their headaches. If I have them stop very slowly, the headaches completely disappear. I had one woman who used to get a headache by an allergy, and nobody could figure it out. So we did a real study with her, and it turned out she had a chicken allergy, which she would get a headache 24 hours later, which was very difficult to figure out. So nutrition has a lot to do with it, and diet has a lot to do with it. And sometimes I work along with a nutritional doctor, and we do a whole blood analysis, and sometimes they're missing something in their nutrition, and so that will also, help them to. So it's usually multi-causation. It's not usually one thing. It's usually a lot of things, and I always try to clean up the diet for most of the clients who have headaches.
Is armor really just tension in the muscles?
Great question. So armor means that your body constricts, and your body can't tell the difference is the cause is something mechanical or if it's something emotional. So there is a big difference. And the difference is that the emotion is causing the contraction. You might have noticed sometimes when you work on somebody, they come back and they're tight again. Okay? And oftentimes, I think about it in terms of you can have mechanical tension from overwork, overuse, that kind of thing, and emotional tension. Now, when we do body work, we can get rid of the mechanical tension, but if it's really emotional tension, which it is frequently in headaches, that's not something that's going to go away unless they deal with that. So frequently when I'm treating someone with headaches, I'll have them see a therapist at the same time if they're open to it, which is sometimes a really important piece. And these days, lots of people are in therapy anyway. And sometimes I have a relationship with the therapist, so I'm kind of talking to the therapist a bit as well. So the way you tell is that it's very resistant. The person, if you like work on their neck or their back, they kind of jump a little bit. That's more of an armoring. Or if you start pressing on the sternocleidomastoid muscles. I remember I had a client who had the emotional tension in there, and as soon as I would try to work on the sternocleidomastoid, he would go like this. He would just like laugh and raise his shoulders up because it was all emotional. And then I got him to go to therapy, and about 8 months later, and it was the Reich's kind of therapy called orgone therapy, and he came back, I touched his neck, nothing. Just completely nothing there. Because that was an emotional piece that I could never have gotten rid of.
Good, that all makes sense.
Great.
And so then what happens to the armor when you get rid of headaches?
You know, when I was starting out my work doing this like 45, 50 years ago, I had a lot of concern about that I didn't want to be messing with people's emotions and energy and doing it in an irresponsible way. So I actually met with several doctors, psychiatrists who did this kind of work with the emotions and the body, Reichian kind of therapists. And I described to them what I was doing, and they said, well, what you're doing is you're helping them to redistribute their armor. It's not going to go away, because unless they have some therapy around it, but it will come more evenly in their body. And they might get a little tighter in the back and their arms, but it's not concentrated like in their neck or in their eyes and stuff, which is dysfunctional for their life. You're allowing their energy to move a little bit so they don't get headaches. They may get other kind of issues, but they're not going to be a totally relaxed person after that. And it's important, particularly when working with migraines, that the person has some therapy that's body-based if possible, that they're talking, that they're expressing their emotions. They might have some communications training where they're learning how to express themselves better. So it gets redistributed, is what I was told when I investigated with these physicians that I was working with. And it was a big concern of mine, too. Thank you all for coming. Let me take a moment to introduce you to some of my DVD training programs that explore the in-depth assessment and treatment of injuries to specific parts of the body. Up here on the upper left, you see the Advanced Techniques series is a DVD version of a full-day course that I teach around the country on myofascial and deep tissue techniques. The shoulder is a 7-disc series that covers the anatomy in tremendous depth, all 30 assessment tests and the history, the integration of all of the information to understand what's injured, and then all the treatment techniques, including myofascial therapy, friction therapy, massage therapy, exercise therapy, and so forth. The final disc is a case study where you see me go through taking the history, doing all the assessment tests, talking to the client, and then doing the first treatment, the third treatment, the fifth treatment, until the resolution of the issue. So you see the whole process that you've learned throughout the DVD. And I do the same for the low back and the neck. Most of the injuries are ligamentous structures. And then I do the knee, which there are 23 different injuries to the knee, and then a series of common injuries, the most common shoulder, elbow, ankle, and foot injury, as well as a hamstring. In an effort to make my material more accessible to everyone inexpensively, I've created a subscription membership. For just $29 a month, people can access over 140 online courses which cover the assessment and treatment of injuries to the entire body, pregnancy massage, oncology massage, ethics, boundaries, and many more. Just visit benjamininstitute.com. Thank you for attending, and keep yourself learning.
Thank you so much, Ben. To learn more about Ben's products and his workshops, visit his website.
If you're an ABMP member, you won't want to miss out on October 10th, when we will host Eric Dalton in an exclusive member-only online event to help you solve your client's pain and injury puzzles. You've never seen techniques quite like these or experienced therapeutic outcomes quite so quickly. This work will change your practice and thrill your clients. Set up your computer, set up your massage table, and find a lucky friend to be your practice body, and work right along with Eric as he walks you through, step by step, each unique technique. Ask Eric questions in real time through live online chat and take quizzes for up to 6 hours of certificates of completion for continuing education. Nothing like this has ever been offered in Massage and Bodywork CE, and only ABMP members get it. If you have massage therapy friends, encourage them to join ABMP now to participate in this one-time only event. We'll see ABMP members right back here with Eric Dalton on October 10th.
Do you think that, our stress caused headaches the most common kind of head pain? How many headaches per year do you think are a normal thing to have? Do you know what else causes headache type pain? And can you tell the difference between a muscle tension headache and a migraine headache? And just keep those in mind. Are they things that you know now, but hopefully you'll know them later? So first of all, let's start with what is a headache? Like, my head hurts, and it can be caused by lots and lots of things, actually several hundred things. But when a person's head hurts for no matter what reason, they call it a headache, even if it really isn't a classic headache. And so you might think for yourself, how many headaches a year do you get? And we'll talk about that, what's kind of normal, a little later. So what can cause head pain? First, if you're thirsty and you haven't drunk anything, you're dehydrated, that is something that causes a headache. That's something that can stimulate a headache if you're on the spectrum to tend to get headaches. So always being hydrated is pretty important. And of course, everybody associates headaches with stress. If you're stressed out, you get a headache because it elevates the level of stress and tension in your body and easily can cause different kinds of headaches. Allergies also can create headaches. You just get around some kind of perfume, or you get around, you eat a certain food, or you have a lot of pollen exposed to you, you might get a headache. All sorts of reasons. Just taking birth control pills, anything that sort of destroys or makes your hormones do something different. And that usually is in women, not so much in men. Although it can happen in men. And of course, if you get a concussion, whether you have a whiplash, or you bang into something, you fall down the stairs, or if you play football or some kind of contact sport and you get smacked in the head, your brain gets traumatized, and that can cause headaches that can go on for quite some time. And a kind of head pain that people don't usually understand or even think about is neck injuries causing head pain. And there are certain parts of your neck that will refer pain to your head, the front of your head, the back of your head, the sides of your head. So we're going to talk some about how pain can be referred to the head. People call it a headache, but it isn't really. It's really a referred pain to the head. And you can have combinations of these kinds of head pains as well, which we'll talk about a little bit later. Now, more than 200 diseases can cause a headache pain. If you have angina or certain heart conditions, you'll get a headache. If you have subarachnoid hemorrhage, that can cause a headache. If you have a cerebral, do that, which is exciting. My favorite thing actually to do is work on headaches, because when they're gone, the person's life is totally different, because your life is really diminished when you have headaches. You can't really do anything. It's kind of horrible. Okay. So let's talk about duration and frequency. If it's longer, it happens for a long time, it's going to be more serious. So if you have a little headache for an hour or two, not very serious. Easy to work with, get rid of. If it's kind of a medium type seriousness, the person's going to have it for most of a day. They might go to sleep, wake up, feel better. And then there are people who have very serious headaches that go on for days, weeks, months even. I remember I had a fellow who was forced to come to see me by a friend of his. He was an MIT professor, very skeptical, tried everything. And he had a combination of two types of headaches. He had a tension headache that was always with him, and then he would get a migraine several times a year that would put him in bed. I mean, just couldn't move. Put it in darkness, he had no sound, it was crazy. And so he was not very interested in coming. He didn't think it would work. So there was zero placebo effect. But myself and my assistant treated him for a couple of months. Headaches went away. He became our advocate. So you don't have to believe in it to have it work. And it was a great case, a fun case for me. So frequency. If you get headaches very frequently, of course, it's going to be more serious. So more severe. So people have severe, they have a headache every day. People are kind of moderate, they have a weekly headache, maybe 2 a week. If it's not so moderate, they might have a monthly headache, and that might be connected, for example, to a menstrual cycle. That sort of happens in that way. And then what's normal? Normal is 2, 3, maybe 4 headaches a year. And we all get over the top sometimes and we get a headache, but anything more than that is not normal. I remember I had a woman who worked in the office where I was working with an osteopath, and she came for a shoulder injury. And whenever I examine somebody, I say, do you have any other kinds of pains? Well, I get headaches once in a while. And she said, well, how often do you get headaches? And she said, well, yeah, just 2 or 3 times a week. And in my mind, I said, 2 or 3 times a week? Oh my God. I didn't say that. I was totally stoic. I said, well, would you like us to work with that too? And she said, oh yeah, sure, whatever. She thought it was normal because on the ads on TV, it says, take Bufferin, take aspirin, take Advil, take whatever. And so it was normal to have that many headaches. But it's not normal. So we treated her headaches and her shoulder injury, and she was really happy. Okay, so not normal. So let's look now a little bit at the anatomy. These are the muscles of your head and face that can contract and give you a headache.
Hi, I'm Brandon Twyford. I am Associate Editor at Massage and Bodywork magazine. I'm excited to introduce Ben Benjamin and his session at the ABMP Head and Neck Summit titled Deconstruct Headache Pain. Your client's headache. Is it a serious disease, a soft tissue injury, stress, or something else? In this hour, Ben will help us figure it out. Ben Benjamin, PhD, has been practicing massage since 1963 and founded the Muscular Therapy Institute in Cambridge, Massachusetts. With a passion for helping individuals cope with and overcome pain, Dr. Benjamin has been lecturing internationally for more than 35 years. He is the author of Listen to Your Pain, Are You Tense?, Exercise Without Injury, and the co-author of The Ethics of Touch. Ben was inducted into the Massage Therapy Hall of Fame in 2010. I recently had the opportunity to participate in a video shoot featuring Ben's work here at the ABMP office. Ben was amazing, so I know you'll get a lot from this session. Enjoy.
Thank you for coming to the ABMP Head and Neck Summit. So I'd like to start out by thinking about the goal. What are we doing here? So the goal is learn how to distinguish between the various causes of headaches and head pain. And they're kind of different. And we're going to be talking about that as we move along. I'd like to have you keep some things in mind. I became a therapist, went to my school, and she now treats people for headaches. So and that was like a number of years ago. So let's talk about muscle tension headaches and what you actually look for. So first you're looking for location. Now when somebody has a muscle tension headache, it's oftentimes on both sides of the head and it changes. When you have a migraine headache, it's a little different than that. And we'll see that as we go along. So it could be like a spot, that you get when you get a muscle tension headache. It could hurt in the front, kind of in the sinus area, under here. It can hurt on your scalp. It can hurt around your head, like a band of tension around your head, like somebody is having a vice around your head. I remember once I had a headache. I got really upset. It felt like somebody was tightening like a metal band around my head. And then I really understood. I don't usually get headaches, but I understood and had more compassion for my clients that had headaches. Also, very common is to have an occipital headache, either on both sides, one side right in the back of the head. Also temporal headaches, one side, both sides, but usually switches if it's a muscle tension headache, and also around the eyes. With a migraine, it's going to be different. It's going to be behind the eyes. So now, what kind of pain do people have? Well, they can have different kinds of pain. So it could be like an ache. It could be like a throbbing. If it's a pounding, it's going to be a lot more intense. Sharp, it's going to be very intense. A dull headache that happens over time, a little less intense. And a person could have intermittent, hurts for a while, then it kind of recedes into the background. They kind of forget about it, even though it's there in a little bit of a way, and they might be squinting. And so all of these are the types of questions that you ask a person. So duration and frequency. So how long or short means a lot in terms of how serious this condition is. So if somebody has a headache for an hour or so, not so serious. If it's a medium type of headache, it might be the entire day, whole day. They go to sleep, they wake up, they're better. But they can't really do anything about it, even with medication. And then people have very intense, long headaches, like for months. They just always have a low-grade headache. I had a client who somebody forced to come to see me who had actually 3 headaches at once, 3 kinds of headaches that alternated. He had a muscle tension headache. He was kind of in a malaise all the time. He had a migraine headache that would just put him out, like he had to go to bed. He had to be in a dark room, horrible. And he didn't believe that the work that I would do could help him. So he was totally negative. They say the placebo effect. There was no placebo effect. He was an MIT professor, and his friend forced him to see me. So I did an evaluation, talked to him, and then we treated him, myself and my person who was working for it. And like in 2 months, his headaches were gone. He was like an advocate after that. His mind was blown that somebody could actually do. Aneurysm, that can cause a headache. A friend of mine just recently had a colleague who went to the emergency room, had a splitting headache, and he went over to the desk, oh, you only have a headache, sit down, wait. He waited 5 hours and then died, sitting right in the emergency room. So doctors make mistakes too, but we don't want to make that mistake. And that's one of the reasons we always refer people to a physician before we seriously treat them for headaches. Also, brain tumor. I had a student who was testing a student for neck problems, and when you turn the head, it's supposed to be very, very strong against resistance. And this person had a very weak head. Didn't really want to go to a doctor, but this therapist said, hey, you should really go to a doctor because I want to be safe treating you. And it turned out he had a brain tumor. And had he not gone to the doctor, he would have died. So very important. Meningitis also can cause head pain as well as different kinds of cancers. So there are several kinds of headaches that are classified, and we're going to work with a couple of them that hands-on work can deal with. But the one we think about most is probably migraine headaches and tension headaches, called muscle tension headaches usually. So there is also cluster headaches, which are kind of horrible, and people have those in a certain configuration, which we'll talk about later. And people can get true sinus headaches, and also sort of people think they have sinus headaches but don't. We'll talk about that. And then the rebound headaches would have to do with medication. So you got the body-based headaches, which are things that our work can help. If you are treating somebody and they truly have a rebound headache, you're not going to help them. If they have an injury-based headache and you don't know how to work with the injury, not going to help them. But if they have migraine or tension headaches, the kind of work that I do, that I teach, can really help that person never have headaches again, or have them, minimally. So just reminded right now of a young woman. She was about 19 years old. Her parents brought her in to see me in my office. She'd had headaches since she was 13 and very slowly became antisocial, didn't want to go to school, didn't want to hang out with friends because her head hurt all the time. And I began to treat her. And she had a combination of two kinds of headaches. Neck injuries that were referring pain to her head that stimulated a tension headache. And so we treated those for about a month, and she was blown away because her headaches were like, once a week, minimal, and she could do the exercises I gave her, they would go away. Then I went on vacation for 3 weeks, and her headaches came roaring back. So that was actually good because then we knew what I did something. So then I treated her consistently for a period of 2 or 3 months, headaches gone, and actually she ended up changing professional ideas